Hello, everyone, and welcome to today's webinar, Building a Framework for Sustaining a Pressure Injury Prevention Protocol in Acute Care. My name is Ana Ornelas. I'm the Associate Marketing Manager at Mölnlycke. I'm pleased to introduce our guest speaker, Deborah Mings. Deborah has been in nursing profession for 43 years. She has a diploma in nursing and master's in healthcare practice and completed the IIWCC. Deborah is semi-retired as a clinical manager and nurse practitioner, working in the area of skin wound and ostomy. She's currently working part-time to support the corporate objective to prevent pressure injuries at Hamilton Health Science. We invite you to submit questions by typing them into the question panel found by clicking on the Q&A icon along the bottom menu. You may submit your questions at any time. We will collect them and address them during the Q&A portion at the end. A link to the certificate of attendance will be available in the chat at the end of the presentation. Please click the link to download your copy and complete it with your name. It will also be available in the follow-up and thank you email. Welcome, Deborah.
Thank you, Anna, and thank you everybody for joining me tonight to talk about a really important topic and something that I'm very passionate about, which is pressure injury prevention in acute care. And I want to thank you particularly for joining me tonight. I know I am competing with Taylor Swift. It's the first Swiftie night, so I appreciate the fact that you've decided to join me here to talk about this. So welcome everybody. And I'm going to take you through some of the work that we have done around pressure injury prevention. And so what I'm going to be talking about tonight is I'm going to be talking about identifying prevalence and incidence of pressure injuries, particularly in the acute care sector. I want to talk about the role of hospital harm and never events in really talking about why pressure injuries are occurring in the acute care centers, and really the importance of trying to prevent them from occurring is really a key focus for tonight. And then I want to share and identify a framework and some strategies that we've used that support prevention of pressure injury strategies in an acute care setting. So that's what we're going to work through over the next half hour or so. So I pulled this article particularly. I looked at a lot of articles, but this is one that I've particularly found interesting because it's highlighted some interesting information that I haven't seen in other places. So for instance, this is a Finnish study. It's from 2018, 2019. It's from a large group of patients. And so this large group of patients, they found the prevalence of pressure injuries to be about almost 13%, the incident about 10%. But this is some information that I haven't seen of. And if you've seen other references for this, please share it with me. But they actually were able to quantify the number of patients coming into their hospital who had pressure injuries on admission at 2.6%. And that's not an easy number to find. Some of the at-risk characteristic that they identified in their study was higher age. We all have concerns about our older patients. The inability to move independently, which we also know contributes to the possibility of skin tears as well. The mode of arrival is an interesting risk factor that they've identified. So, if you're coming in by ambulance, then you're obviously in not as good shape as somebody who's arriving in another mode of arrival, being underweight. And then another key feature of this study was the absence of a pressure injury risk assessment or skin assessment on admission really then contributed to the patient being at risk, because we're not identifying those patients who are at risk and starting to put our pressure injury interventions into place. So those are some key features from this article that I really liked and wanted to share. Just overall in the literature, the prevalence rates really vary, but really what we see here is that we all globally have an issue with pressure injuries, and we're all working on trying to prevent them from occurring across the world. I've also noted this is our Canadian study. So this study here combined the US and Canada, but we all know from our Woodbury and Houghton 2004 study that our sector is about 26%. And I feel concerned for our older patients and the impact that developing a pressure injury can have on our patients who are older. 15% of elderly patients will develop pressure injuries within the first week of hospitalization. So again, that risk assessment is so important. The ongoing skin assessment is so important. Getting interventions into place quickly for our at-risk patients is extremely important for our elderly patients. For those admitted to long-term care, you can see pressure injuries are most likely to develop within the first 4 weeks. And the whole concern around the mortality rates associated with pressure injuries are as high as 60% for our older patients within 1 year of hospital discharge. So those are all interesting pieces of information, and as I say, the concern around our older patients is absolutely real. I'll just highlight some of the things. As of 2023, the number of reported incidents of healthcare acquired pressure injuries has increased, and this is data reported by the Canadian Institute for Health Information. It's a hospital harm, and so they have identified the rising number of incident of pressure injuries. They've identified out of that year 6,804, which is an increase of 35% from the previous year. So these are ones that have been reported into the Canadian Health Institute. And we know that there's an economic burden. We know that a single pressure injury has a cost ranging from $26,000, up to $230,000 as an estimate. And it increases nursing hours in the community. The costs as well are substantial. I think we can all agree that pressure injuries are underreported. So what's concerning is we're actually getting more reporting of these numbers, but we're probably still not capturing all of the incidents of pressure injuries that are occurring. Pressure injuries have a negative impact on our patients, their quality of life, their psychological level, their loved ones who have to look after them. So it's quite, I believe, quite a significant issue. And in terms of disease priority, let me just go back here. You can slide this arrow around. I've kind of put it here because I think the pressure injuries are much more talked about. A lot more work is being done in them than it was before. I think before it was down here, but we certainly, have a lot more that we can do in terms of putting more priority into pressure injury prevention. And you can certainly challenge me on where I put this, and we can talk about it in the chat if you'd like. So I want to talk about pressure injury development in the context of never events and hospital harm. Hospital harm is defined as the rate of acute care hospitalization with at least one occurrence of some sort of unintended harm during a hospital stay that could have been potentially prevented by implementing known evidence-based practices. So I've been a nurse for 43 years, so I've been around for a while. And when I first started out, I remember explicitly being told in nursing orientation that if I made three serious errors of any sort, that there was a possibility that I would be terminated. And so that kind of atmosphere really created an environment of of harm and not reporting when errors occurred. So it's good to see that evolution, that we're acknowledging the fact that things do occur in a hospital. We need to identify them when we need to report them, and we need to deal with them, which is about this whole hospital harm philosophy, and the identification has been about never events. We know that in 22-23, 1 in 17 hospital stays in Canada involved at least one harmful event. And so that is, you know, kind of a significant number out of the event. And this is just a bit of an infographic that kind of demonstrates that. So this 1 in 17 hospital stays result in some sort of harm. And we can see, if we were categorizing what these events look like, and this is from 22-23, 46% or almost half are healthcare and medications, and they're related to things like pressure injuries and medication errors. So that's kind of the first grouping. The second grouping of hospital harm, about 31%, is infections, surgical site infections. The 18% is procedure-related issues like bleeding after surgery, and then falls are the last category in terms of hospital harm and where we're experiencing it the most. So pressure injuries definitely factor into hospital harm, and factors into the whole discussion around never events. So these are events that Healthcare Excellence is identified, and Ontario Health is identified as events that we are trying to prevent from happening. And they're identified as patient incidents that result in some sort of serious harm or death that are preventable using organizational checks and balances. They do not imply blame, but they are really a call to action. So we identify them and we start to be able to put our strategies into place. So there are actually 14 never events. Number 9 is any stage 3 or 4 pressure injuries acquired after hospital admission, and that is deemed a never event. So not all never events meet the definition of a critical incident. So we've had pressure injuries that occur that haven't resulted in death, and so they're not critical incidents, but we certainly, again, want to prevent these sort of harmful events from happening to our patient. And just to give you some examples of some other never events, they include surgery on the wrong body part. We never want to see that happening. Unintended foreign objects left in following a procedure, wrong route administration of chemotherapy, infant abduction. So those are all considered never events, and pressure injuries are included in this description. So as of January 2024, never events are being reported to the Ministry of Health twice a year. They take that data and they anonymize it, and then they share it so that people can really have an understanding of what's going on in organizations around these type of events. So I just want to give you, I'm going to circle back to never events and where they've played a part in our sort of development of our strategy. But just to note about Hamilton Health Sciences, which is the organization that I work for and have been doing this work around pressure injury prevention. We have a very large healthcare system. We provide care from pre-birth to the end of life care. We see, micro-preemies from 23 weeks to 109-year-olds. Our multi-site hospital has over 1,400 beds, 15,000 employees. So we're quite a large organization. And we have expertise in a number of different areas. We have cardiac, stroke, trauma care, cancer care, palliative care. And there are 6 inpatient sites, including acute care, rehab, and post-acute care, including medically complex. So we have quite a large range and type of patients that we see in our organization. And, and quite often these patients, because we are a tertiary care center, they are the sickest of the sick. So I just want to talk a little bit about some of the framework that we have used in pressure injury prevention in our organization. And so our organization has has a process called In Your Objectives. And these In Your Objectives are objectives that we focus our energy on. And pressure injury prevention is an in-year objective for our organization because pressure injuries tend to be our most reported never event. The organization decided to put a lot of focus into energy in their prevention. And so these are some of the things that we have done to work on our preventative strategy. So the framework includes having this corporate structure, setting goals, which is extremely important, collecting data to set goals, and really understanding what is going on in the organization with our pressure injuries. We also have used our documentation system to leverage pressure injury prevention and to obtain this data. So we've used our systems in order to get the data that we need to help us set our goals and understand where we are. We are a CQI, or a continuous quality improvement organization. We use those tools to support learning in the organization. And so we've used our CQI tools to help us in pressure injury prevention across the organization and on the clinical units. And I'm going to share a really great example of how clinical units, which is where it's at in terms of prevention, have used the tools to really help inform pressure injury prevention and improve what was going on in their clinical unit. We have really put together a collaboration with educators and our interdisciplinary team to translate knowledge into action. And so one of the things that we really acknowledge is the fact that our clinical group, our NSWACs, who will provide our frontline, or who provide our specialized care, are our content experts, but we have experts in knowledge translation. And so we put this group together as a team and collaborate, we can really produce some outstanding results in terms of the education that's required to move the needle forward in pressure injury prevention. We've developed a substantial number of educational tools and resources to support all of this learning. And we're also trying to explore some technology and innovation to see if there's ways that we can really work to use that technology to help us in the early detection of pressure injuries. So let me just talk a little bit about the corporate structure and take us back to the never event conversation. So we started, Health Quality Ontario started to talk about never events back in 2016 and started to encourage organizations to look at ways of collecting data for these 15 never events. So we started in the process of collecting the data, and it took us a couple of years to sort of figure out how we were going to get our data and where we were going to get our data from for these 15 never events, including pressure injuries. And so we started to collect our pressure injury data for deep tissue pressure injuries, unstageable, stage 3s, and stage 4s through our adverse reporting system. So this is the report. We all have a system that we use to report our adverse events. And so ours is RL Solution. And so we started to use that data to get a sense of where our pressure injuries were occurring, what clinical units, what severity, and what level of harm was done. And so it's actually our NSWACs who are responsible for reporting these events. They are the people who are seeing our more complex patients, including our patients who are developing pressure injuries. And so they are the ones who are using our adverse reporting system to collect our data and to put this into our system. And so once a month, then one of the NSWACs takes all of this data that has been submitted by the NSWACs throughout our organization, and they review it to make sure that it is accurate. They review it to make sure that it matches the description. And then they develop a report that identifies how many stage 3s, stage 4s, and unstageable pressure injuries that were occurring, and our deep tissue pressure injuries. And so that's how and then that data is actually reported throughout our entire system. And so it's an extremely important role for our NSWACs to be reporting on what they're seeing out in our clinical units. And then we collect that data on a monthly basis, and it gets reported throughout up to the CEO level and the executive level. And so that's one piece of our reporting system. So we've got our adverse reporting system where we got our monthly data, the stage 3, the stage 4, the unstageables. And as I say, that is reported throughout the system. VPs get a report, our board gets a report, our managers have access to a report, and our directors have a report about what's going on clinically across the sites and across the clinical units. We have also developed a Braden scale dashboard. And so we have Epic as our documentation system. And so our data governance people have figured out a way to pull our Braden information into a dashboard that is, again, used at all levels of the organization to identify our patients. And so they we collect information of Braden on admission to a clinical unit, and they've also figured out a way to break that down to a risk level. So patients on clinical units, a manager can pull up a report that says we have X number of patients on our unit. We had 87% of our Bradens done on admission. We had, out of those 87%, we have 25% of our patients who have a Braden scale of 10 or less. And so, I mean, it's a fabulous report. It provides a lot of information about what is going on in the organization, and it is accessible to everybody, managers, directors, VPs, like everybody across the organization. So we also, in that dashboard, collect Braden during hospital stay. So they record and they're pulling out of documentation. And one of the comments that you'll have is, you know, it's only as good as the documentation. And yes, that's absolutely true. So we'll talk about that in a little while. But we do get these reports, and they're quite robust, and they do give us this type of information about what's going on in our hospital and what's going on around risk assessment and what's going on about the interventions that are put in place. And so that's kind of our reporting on two levels: our monthly data from our RL Solutions adverse reporting system, and then our dashboard that we have access to. And when you put those two pieces of information, you have a lot of really salient, important information about what's going on in your organization. So corporately, and because this is a corporate initiative, the occurrence of hospital-acquired pressure injuries based on our 2022-23 data, we set it at about 13.8, and that's our average pressure injuries per month. And considering we're a huge organization, we have 6 large sites, we cover everything from preemies to old age. That's kind of our current level. Currently, we're trending downward, about 10 per month, but we do see these seasonal fluctuations, and we do see these occurrences where we've had these blips where we've had an increased number of pressure injuries coming from a site or from a unit. And so the beauty of the reporting is that we can actually circle back and start to talk about, well, why are we having these blips? So what are we seeing? You know, is there a resource issue? Was it a staffing issue? Was it a patient issue? And we can start to look at why we're having those occurrences. The other, the other corporate piece that gets reported is this Braden scale completed upon admission. And so initially our target was set for 75% when we started doing this. And then the target was set higher because people were doing their Braden scores on admission. And now we're trending about 80 to 90%. So people are, frontline staff are very good about doing their Bradens on admission as a part of the whole package of risk assessment they do for our patients when they're admitted. And then just to give you an idea, this is our sort of structure that we're working in. We're doing corporate work. And then we're doing our A3 work, which is our CQI work on our clinical units. And so corporately, we've really focused on education, that collaboration with our education clinician colleagues were focused on making sure that our documentation is robust in EPIC. And there were actually, if we've got an assessment that we need to do, we actually have the appropriate documentation to support it. And I'm going to talk about that in a second. The data reporting piece, we've pulled out two big pieces of work around that, which is the monthly reporting and then the Braden scale. But we're also looking at ways of how can we use our EPIC to pull out other sort of data in the organization. We are focusing in our acute care and our rehab units for our preventative work. And we have a subcommittee that's been working on surface and bed frames to see about trying to bring more therapeutic surfaces into the organization. And also our technology group with innovation, another collaboration, trying to find technological solutions for early identification of pressure injuries. So just a little bit of information about what does our data tell us from 2022-23. So when we're looking at hospital-acquired pressure injuries, the first number we see is unstageable pressure injuries. So those are the most, followed by our stage 3 pressure injuries, our deep tissue injuries, and our stage 4 pressure injuries. So having this data can really help you quantify what's going on. What's interesting, though, is the majority of our patients are transferred, discharged, or deceased before we see what happens to our unstageable pressure injuries. So we don't always know the outcome of our unstageable pressure injuries. We do track and we do see, as long as the patient's in the hospital, all of our unstageable patients and all of our deep tissue injury patients to see what is the evolution of our pressure injuries. But once they leave our organization, we don't track any further. And so we don't always know what the outcomes are. What's interesting, though, is when you break down looking at sort of heel ulcers and coccyx ulcer, which are our most pressure injuries, our heel ulcers tend to be in our patients who are over 80 with unstageable hospital-acquired pressure injuries. And the majority of the patients have Braden scales of 15 to 18. And so, you know, these aren't necessarily the patients who would think that they're at most risk, but I think their age really does then, and the fact that there's not a lot of subcutaneous tissue over their heels, they're having hip surgeries, knee replacements, and so I think that heel ulcer data then makes sense. And then our patients with coccyx ulcer tend to be over 65, again, starting with the unstageables and stage 3 hospital-acquired pressure injuries. But they have a Braden scale between 10 and 14, which makes the most sense in terms of risk. So I'm just going to talk a little bit about using our documentation systems to leverage pressure injury prevention, because what we're really trying to do is we're trying to marry all of our strategies together. We're trying to marry our education, our documentation, and our data so it all supports each other so that we can do the work on the clinical units to prevent pressure injuries from occurring. So we've done a couple we've done some buckets of work. And so one of the things that we have developed is an order set. So in EPIC, you can have different order sets. So they're automatic orders that a staff nurse or an RPN, a registered staff, can to go into EPIC, and they can download an order set that already has information about pressure injury prevention on it. And they tick off the pieces that are the most relevant. They send it off to the physician to get signed, and then they can start on pressure injury prevention. And I think one of the things that I'm most proud of the work that we've done is we've actually developed documentation around prophylactic dressings and prevention. Because one of the things that we noticed was that we didn't have a place to document any of the areas that we were concerned at being at risk. And so now we have developed documentation that supports that, that staff can fill out. And if you were at Wounds Canada, you know that there was a presentation by Rebecca Dick, and there's been a significant amount of work from McMaster on developing 4 Ts, which is documentation, more documentation, comprehensive skin assessment for patients with darker skin tones. And so this is kind of some of the work that we're doing. Just to give you an idea of what's on the order set, it's a pretty comprehensive order set. It includes, and this clinical judgment is a component of this. And so up for meals is tolerated as long as the patient's able to do it. Head of bed elevated as long as the patient, or last 30 degrees or less, again, as long as the patient's able to do it. We have integrated a therapeutic surface order into this. And so you can order therapeutic surface right from Epic. You can get dietitian OT-PT consults, and these are for patients at risk or who are developing early stage pressure injuries. Implementing regular turning and repositioning, elevating the heels. There is an education link that you can put on to get education for patients and families on pressure injury preventions. I have to say not a lot of people use it, so that's one of the things that we need to work on. And there are wound care orders for stage 1 and 2 pressure injuries to get started, and incontinence care orders. And so all of this is to get our interventions into place early by using this early order set. And this is just to show you our prophylactic dressing, the work that we've done. So you can see that we've got this is our integumentary system documentation. We can do drop-down menus to pick the type of therapeutic surface our patients are on. That SpO2 probe relocated is for feeds, but we're actually going to be doing a more comprehensive drop-down list for our medical devices. We've integrated the Braden scale here. We've now integrated documentation for prophylactic dressings. And, now we can communicate if we have concerns, if we're seeing a patient who has at-risk areas, and we've applied a prophylactic dressing. And so this is the avatar. So we have a body in Epic that we can put lines, drains, and wounds on. And now we have a bullseye symbol that we use if we're using, in this case, a Mepilex border for prevention in our patients. And so this can be followed along. If this does end up progressing to stage 1 or 2 pressure injury, then we actually discontinue this and we start our charting then on our wounds assessment documentation. So we've tried to connect the pieces. And we're hoping over time to be able to pull data from this piece of work, this documentation that says how many patients are at risk for skin breakdown in the organization, how many patients actually progress on to have a pressure injury over time and end up getting a stage 2, 3, 4 or unstageable pressure injury. So that's what we're looking at in terms of being able to pull from some of our data. This is some of the work from McMaster. So this was this is the bias and skin assessment that was noted. This actually observation initially came from a physiotherapist who noticed that patients who had dark skin tones were actually developing, or we were seeing their pressure injuries develop at a more progressed rate. And so there's been an identification of a bias in a skin assessment. A lot of the pictures we see are patients with light skin tone. And so we're really trying to up our games in terms of a more comprehensive skin assessment. There has been some work done adapting a scale from Ho and Robinson. And what the team at McMaster has done is they've actually put in like the grid. And what our documentation is going to do is that on assessment, we're going to be including this important piece of information in our skin assessment on admission, where we look at the skin tone of the arm and then we document whether we're seeing an A1 or a 6B, and then that change in skin tone over time. We've got our initial assessment, and then we can be monitoring over time our patients in terms of their skin tone. And that's the color bar. And so the work that they have also done includes the 4 Ts, which is also going to be added to our documentation. The tone, the temperature, the texture, and the twinge. So any pain, which often precedes a color change, this will also be included on our documentation. And again, we'll be able to pull data to see how it's being used and how many of our patients are having these type of issues. We do CQI in our organization. So CQI is a continuous quality improvement management system. It's a set of tools and behaviors that focus on setting up our people and our processes for success, and ultimately providing quality to our patient. And so these are the tools that we use. We have a status sheet, which is a standard sort of reporting sheet. There's very clear leadership teams. There's daily huddles. So the group comes together for 15 minutes a day to gather and review and prioritize patients and what's going on in the clinical units. There's a problem-solving approach that's clear. Standard work, one of the things we all have issues with is that there's a problem and 5 different people do things 5 different ways. And so standard work is a tool that we use to really clearly identify steps that need to be taken in processes. Process observations are very important. They help us to visually review what's going on and to determine whether or not our standard work is actually being followed, and reflection. And so it's a whole way of sort of thinking and doing our business. And so we had 24 clinical units participating in pressure injury prevention over a 3-year period. And some units have been involved in the process, and they're not doing the process anymore because they improved their pressure injury numbers. We've added on new units. And so the criteria we used for adding in units to participate in like our formal pressure injury prevention work is having 4 or more pressure injuries recorded over a 1-year period of time, or some units volunteer because they want to do the work to ensure pressure injury prevention occurs on their units. And so we have about 48 clinical units. So half of the units participated in the actual formal work of pressure injury prevention. And those were the units that were identified as having the most risk. And we use this process. So when we started, all units got a problem statement, they got our process observation cards, which I'll talk about, and they got a fulsome package of educational resources to support them. So this is just an example. I just wanted to show you an example what a process observation looks like. And so it's an effective way of getting information on what is occurring on a clinical unit. So you're just taking 3 areas that are being identified. So instead of doing an overwhelming audit of your situation, you take 2 or 3 issues that you really want to drill down on what's going on in the clinical unit. So in this case, was the brain score completed at the time of admission? And were patients on low brain score discussed at the safety huddles? And any patient requiring a specialty surface, we use isoflexes, were they flagged and discussed? And then were the focus photos taken on admission? And were they done weekly? And so those are the things that they were focusing on. And so what would happen is a clinical leader or somebody would be assigned to do 2 or 3 patient charts and review whether these things were happening, and then bring that information back to the board and to the clinical leader and to the manager. And so you do some observations over time. You'd have different observers identified, and you decide whether or not the observation was red, everything was being done, or green, it wasn't being done. So it really does help you to keep track whether or not you're doing the things that are important around pressure injury prevention without making it an overwhelming amount of work. And then out of these process observations, you start to figure out where are your gaps, where are your problems, what are you doing well, what are you having struggles with, are you having issues with resources? And so this particular team were doing their process observations, and then they did this root cause analysis of what was going on, because they had a spike in pressure injuries on their clinical unit, and they wanted to figure out what was occurring and why it was occurring, and start to put measures into place to find solutions for their problems. And so I think that this is probably this is a great piece of work, because we all, whether you're in an urban or a rural setting, we're all struggling with who's doing what, who's telling the doctor, do we really understand what the brain scale means? Because you can do a risk assessment tool, but if you don't actually understand what it means, then it's not a helpful tool. Do we understand wound staging? Wound staging, I think it appears to be simple and straightforward, but when you're actually trying to do it in real life, there's some nuances to it that people really struggle with, and understandably. They really wanted to make sure that the team was aware of the best practice prophylactic measures that we were putting in place, and were they clear about what they were doing? Were they doing 2-hourly positioning, early mobilization? Were they doing a correct documentation? And so these are some of the things that were important. And, were the escalations and anything changes in patient conditions actually being reported? So they identified all of these issues as contributing to their pressure injury problem on their clinical unit. And then they set about to do work. They assigned who was doing it, they assigned time frame, and they did the work to make sure that it got done. So safety huddles are key components of CQI. And so every morning at 8:55, a group, charge nurses, physios, OT, meet for 15 minutes at the most, and they review all of these clinical issues that impact the safety of their patients. And so what they did is they actually added in information about making sure that they identified any patients who needed an isoflex, any patient who had a low brain scale. Do they currently have a pressure injury? What stage were they? Did they need a wound consult? Have they taken their photos? And so they incorporated this into their daily discussions around patient safety. And then they did this really excellent education board. It's accessible to all staff. They did a number of reviews, lunches and learns. It included the brain scale, the staging, the prophylactic dressings, and you can see, they made sure that they identified their prophylactic dressings with a P, pressure points, and preventative strategies. So they outlined all of this on their board as a way of dealing with some of the issues that they had identified. And then up on their CQI board, which is a board that contains all of the work they're doing on a variety of strategies. This is what they've emphasized: taking their pictures, getting patients on isoflexes, using preventative dressings, getting that order set early, that's for early intervention, and making sure that a wound care consult goes to the NSWAC as quickly as possible when a progressing pressure ulcer has been identified. And so I just wanted to highlight that work because, we do all this work corporately, but really the work, when it's translated down to a clinical unit like this, and you see results with patients, not developing pressure injuries, which is what you want, that's really where the work is all about. We did a very successful collaboration with our clinical educators. The 3, 4, 5, whatever number of NSWACs or wound care clinicians in your organization are not responsible solely for pressure injury prevention in the organization. The organization as a whole is responsible for pressure injury prevention. And that means using your resources wisely. So the NSWACs are focusing on their clinical component and the educational piece they have, but we're also using the expertise of our educators in translating the knowledge. And so when we were rolling out our prophylactic dressing documentation, the new avatar, our Mepilex dressings, that to be used prophylactically, we did a whole educational strategy, and we rolled it out to the entire unit, all at the same time. So the clinical educators got a package of information with a curriculum and a resource package with all of the information they needed, so that when we completed our work around that documentation, we were ready to go. We had our education ready to go. And so we could match the documentation then with the education that we were doing to the actual frontline work that had to be done. And so again, another good piece of work, pulling all the pieces together and taking that information and translating it at the same time in an organization our size. So everybody got the information and they could proceed with using the prophylactic dressings. And so this is some of the information that all of the educators got. And then because we couldn't possibly always hit all the stuff, we then used our vendor, Karen, in this case from Mölnlycke, to support us in the education and the reinforcement of using our prophylactic dressings. And so this is, I just wanted to show you, this is some of the educational resources that we created. This is a pressure injury prevention care plan and an initial treatment plan. It's on 11 by 17. So this is for adults, there's one for peds. And so this is sort of a pressure injury prevention and early stage management and staging at a glance. And so it's on all of the clinical units. It's included on all of the packages for all of the educators to use with their staff. And then the last piece that we're exploring is our technology piece. And so we're looking at the Mimosa Pro, which is a handheld wireless scanner, uses infrared light. And we're using that in response to the patients that were identified at McMaster Children's Hospital who are developing pressure injuries with darker skin tones. And so this is a piece of technology that we're going to be trialing in both adults and in peds to see whether or not we can pick up patients who are developing pressure injuries at an earlier stage and get our interventions in place. We also want to see how it compares to the Braden and how the Braden is picking up patients at risk versus this piece of technology. So that's the work that we are currently doing. So trying to mesh all of these strategies together to decrease pressure injury prevention in the organization. And just some final thoughts. You need commitment at a senior level to do this. If you're just a lone clinician trying to do this work, it's going to be very, very challenging for you because you really need that senior level support for resources, for data management, and for reinforcement. You need to look at methods of extracting data from your organization, systems that are already there. So you're not reinventing the wheel. You're using your current systems to try and pull that data that you need in order to identify what your pressure injury prevalence is in the organization. And you need, again, we used our CQI to create so our process is already in place. We used our educators to support the rollout, and we really leveraged and shared the work to try and get it done in a huge organization like ours. And so I'm gonna stop now and entertain some questions.
Thank you, Deborah. Let's begin our Q&A session. As a reminder, you can still submit questions through the Q&A icon. So we have already a few good questions here. So let's get started. Our physicians tell us they don't want to co-sign a prevention order set. How can we include all scopes to initiate and implement an order set plus involve physicians?
Great question. I'm not sure why physicians would not want to participate in preventing pressure injuries from occurring. And so there's been some, so the unit that I highlighted that did all the CKI work also engaged their physicians quite significantly. And so engaging physicians is very important, very challenging, I realize, but it really is essential that physicians are involved in pressure injury prevention. I mean, all I have to do is sign off an order set and then it's implemented and you move on from there. The only other way to do that is you could do it through a medical directive that says a patient with a brain scale automatically has these sort of things done. And so it's up to the nursing staff to move forward. So there are a couple of ways that you can do that. But, having physician support, it's really challenging to understand why a physician wouldn't want to be involved in like this very important patient situation, prevention of pressure injuries from occurring.
That's great. We have another question here. Interested in hearing the prevalence and incidence of pressure injury in smaller rural facilities versus larger institutions.
That's a good question. I don't have a lot of experience in rural settings, but I would think the same factors and situations that exist in larger centers exist in rural centers as well. Patients coming in extremely ill, older, they're coming in, they're fragile, they're sick, staffing issues. And so I would think that the prevalence and incidence in rural centers and urban centers would be fairly similar. I mean, certainly tertiary care centers see the sickest of the sickest patients, but I think in the world we live in, probably rural centers are seeing a lot of very sick, fragile patients as well. So those same risk factors exist. So I don't have specifics around the difference, but I think it's an interesting question to ask. But I do believe that the risk factors are the same. We're all struggling with the same clinical issues.
Great. Another question here. What therapeutic surface do you deploy with the standard order set within EPIC?
So we have two sort of processes. So our clinical units, a lot of them have, or all of them have a fleet of Isoflex or Isotor mattresses as our standard therapeutic surface that we use for our patients at risk. And so they use those surfaces, they move them around. But if a patient has a moisture issue or other issues, we also have access to a rental fleet. We use Arjo then, and we can rent for patients who need surfaces beyond our standard Isoflex or Isotor mattresses. So we have our own resources, unit-based resources. We're aiming to get 100% therapeutic surfaces in our organization. So every patient in acute care is on an Isoflex therapeutic surface. We're not quite there yet. There are some organizations who have done that, and I applaud them, but we're working towards that. But we do have a rental solution as well.
Great. Another great question here. I work in home care. Wonder if there is a hospital protocol being developed in order to communicate wound care orders as patient transition to home. As you can imagine, communication is not always great.
Good question. There is supposed to be communication we're supposed to do a transfer of accountability when we're discharging our patients to home with sort of a complete outline of what has occurred in the hospital, including pressure injuries. And so that is supposed to occur. It sounds like the question is that is not always occurring, but that is supposed to be occurring within a hospital setting. So if it's not occurring, feedback back to the organization is extremely important, to say, like, you didn't report this. And so we need to know when those type of things are occurring, because it's essential that a thorough transfer of accountability occurs, including any pressure injuries that are hospital acquired.
Okay. Another great question here. So sites implemented a provincial first MDRPI prevention protocol for critical care to foster collaboration with nursing and share specialized skills between disciplines. Interested in interdisciplinary framework for engaging staff and improving care.
Sorry, can you repeat the question?
Sure. Sites implemented a provincial first MDRPI prevention protocol for critical care to foster collaboration with nursing and share specialized skill between disciplines. I'm interested in the interdisciplinary framework for engaging staff and improving care.
Oh, okay, great question. So I didn't go into a lot of detail about like our committee structure, but we include OTs, in a lot of our frontline work, our documentation committee has OTs, dietitians. We absolutely use and value our interprofessional care team when we're developing resources, when we're creating documentation, when we're rolling out resources. They are absolutely essential to doing that. And so, you know, we have practice councils, and so we take information that we're working on and that we've collaborated with OTs to practice councils for discussion, so that we get a more fulsome review of the work. And we make sure that it really reflects the disciplines that we're working with. So I think it's inclusion in committee work, it's inclusion in review work, and it's inclusion in frontline rollout. The OTs are extremely important in pressure injury prevention. So are the PTs, so are the registered dietitians. We couldn't do pressure injury prevention without our interdisciplinary colleagues. Because it is more than a nursing issue. It is an interprofessional issue as well.
Thank you, Deborah, for your engaging talk. We hope you all enjoyed today's webinar, Building a Framework for Sustaining a Pressure Injury Prevention Protocol in Acute Care. Don't forget to click in the link in the chat box to download your certificate of attendance and complete with your name. A follow-up email will be sent next week with an opportunity to view the on-demand presentation. And again, with a link to the certificate if you're unable to download it today. If you have any other questions, please contact us by email at info.ca@mölnlycke.com or contact UNTS Canada at info@untscanada.ca. On behalf of Deborah, Mings, Mölnlycke, and UNTS Canada, thank you for joining us today. Enjoy the rest of your day.